Hello, and welcome back to our clinical case series. I hope you're enjoying what you're seeing so far and excited to learn more along the way. Today's case, what we're going to discuss is going to be a posterior implant placement, tooth number 5, with a 3D printed 2 millimeter sleeve guide with Sprint Ray Technologies, followed by a 3D printed provisional to a tie base. This has been a new workflow for me for about the last year and a half, being able to print accurately to a tie base, making these restorations look like they're almost final restorations. The printing's incredible. With this printing technology, we're using the Midas. So we'll talk a little bit more about the differences in printers, the benefits of having the Midas versus the Pro 2, or why one may want both of those printers. So sit back, relax, and let's walk through this case from start to finish. I hope you enjoy tonight's lecture. As always, a few learning objectives I want you to understand and take away from today's lecture. I want you to be able to accurately plan and place an implant for tooth number 5 using 3D cone beam technologies and surgical guides, achieving proper implant positioning. I want you to be able to learn how to design and fabricate 3D printed provisionals, whether that's to a tie base or whether that's to a temp cylinder for tooth number 5, really to establish the emergence profile and the supporting soft tissue shaping and the aesthetics during the healing phase. Lastly, I want you to be able to integrate the 3D printed workflow after placement and being able to deliver this chairside within minutes of that restoration being fully printed. So here's today's case. As you know, I use DTX Studio to design these surgical guides and to print these guides in Office by sending those file types to the printer. So if you want to learn more about my whole workflow and how I plan, jump over into my modern periodontal concepts. You can see this case and how I'm able to plan the implant placement and the guide within about 5 minutes chairside with the patient. So today's lecture is not about going through the step-by-step process. Just understand that I use DTX Studio and it will design a guide, whether that's a 2 millimeter sleeve guide or a fully guided surgical guide. We use different printers for different purposes. I have both the Sprint Ray Pro 2 and the Midas in my office. What I'm using the Pro 2 for in the office these days is going to be for printing surgical guides, clear aligners, models, night guards, and my All-on-X resins. What I like to do when it comes to the Pro 2, just as a side note, is I have different trays for different resins, right? So in the cabinets above my printer, each different tray is labeled. We pop it in, and the machine is ready to go. What I use the Midas for is printing single unit crowns, really to tie bases or for my implant restorations. The Midas is able to print these crowns within about 7 to 8 minutes. It's incredible in terms of the workflow. So here's a picture of our surgical guide with our 2 millimeter sleeve guide bonded into place. So I want to show you how this works chairside here for this case. So here's tooth number 5, an edentulous site that has healed with adequate space for implant placement. So I want to walk you through kind of my step by step. So I want to show you a surgical video for tonight's case. Again, if you want to learn more about in-depth step-by-step surgical procedures, jump over into our surgical mastery course. You'll really enjoy seeing the subtle nuances and the intricacies when I walk you through everything in a lot more detail, step by step. This is a little sneak peek of what that course will look like. So we have profound anesthesia on the upper right posterior sextant. For this case, I'm going to do a mid-crestal incision with a 15C blade. My preferred blade when it comes to flap and incision design is going to be a 15C. I do not like a 15 blade for my delicate, intricate procedures. Now we're going intrasulcularly on tooth number 4 and tooth number 6. Now, my flap reflection in this case is going to be minimal. I want to take a minimally invasive approach to my incision design. My next tool that I will use will be my Orban knife. So you can see how I'm scoring the periosteum going down to bone on my mid-crestal incision and on my intrasulcular incision. Where I like the Orban is to really help with that papilla reflection. So you can see in the video now, I'm able to gently tease that papilla off the bone. Some people may like to use a number 9 periosteal for this, but I just find the thinner blade tip on the Orban really helps lift the papilla. This was a case that I extracted and grafted about 6 months prior. The graft of choice for this case was a mineralized cortical small particle graft, followed by a resorbable collagen membrane. You can see here I'm measuring tissue heights. Why? Because we want to know how deep to place the implant relative to the crestal bone. We know that the establishment of biologic width around implants should be approximately 4 millimeters. So if my tissue height's 3, I'm going to need to place this implant about 1 millimeter subcrestal to allow for the appropriate establishment of biologic width. One of the things I've noticed as I teach other clinicians how to place implants is when it comes to flap reflection, especially on the palatal aspect of the maxilla, we need to be able to see where that ridge starts to fall off on the palate. So I need a full thickness flap extending palatally. That tissue, as you can see here, is firm and bound down. It's dense connective tissue. But by but but by being able to visualize where we're at, it allows for better implant placement. So here is our 3D printed 2 millimeter sleeve guide from SprintRite Technologies. Now you can choose to change the tightness of this guide. I like my guides to sit passively so they don't lock into any areas. So what will happen is I will hold this guide down with 2 fingers and I'm going in to place my first drill. When it comes to our drilling sequence, our 2 millimeter drill, this is a guided drill, so it's longer than our standard drills. This guided drill is marked at 7, 10, and 13 millimeters. So we're at to 7, 10 in a pumping action to 13 down to depth. And that's how quick I'm able to get in the ballpark with my osteotomy. So you could see how if I use this type of guide for multiple implants, that are directly next to one another, how quickly and accurately we can get into the proper placement without having to think, without having to measure. It works wonderfully. So with this case, we're placing a 3.5 Noble Active. So with the 3.5 Noble Active, there's really only 2 drills in the drilling sequence when the bone is soft. So this is my next drill size in the drilling sequence. And again, we're going to be placing the 3.5 by 11 and a half. I've used the drill extender in this case so that my handpiece, the head of the handpiece, won't hit the adjacent teeth on the osteotomy. But notice that there's no finger rests here. So, and we're drilling like a drill press, up and down, back and in. What I find with people with placing implants and you're early on in your career is you like to use finger rests. Well, that will alter the drilling depth and how we drill those cases. You'll become more off-angled and offset because of that distal finger rest or that mesial finger rest. So the osteotomy is done. What I like to do at my office is I like to decontaminate the osteotomy with an NDA laser prior to placement. So this is the NDA laser, and I'm going to use a long pulse duration, a pulse duration of 550 or 650 microseconds to get hemostasis and to decontaminate in the osteotomy. Power setting here is 4 watts, and we are at 20 hertz. Again, this is the Periolase MVP7 laser. More on that laser in other lectures. One of the things we like to do prior to placement is we will photo functionalize our implants, meaning I'll put my implant into a UVC light. Why is that important? Well, when implants come packaged dry, their surface is hydrophobic. By putting the implants into UVC light, it changes the polarity of the implant surface from hydrophobic, water-hating, to hydrophilic, water-loving. Watch what happens when you put this implant into the osteotomy. I'm checking to make sure I'm on the torque setting for the drill, but look at how that heme wicks up the implant threads. Try that with your next implant. You'll notice if you get a dry packaged implant, this won't happen because that implant surface is hydrophobic in nature. What this does is this increases the bone to implant contact to about 95 to 96%. So if an implant contacts more bone, it's less resistant to disease, in my opinion. An average bone to implant contact on an implant with a hydrophobic surface is about 50%. So my implant handpiece torqued out. So now I'm going to drive the implant in with my implant driver. The one thing I want you to notice in this video with the implant driver is notice that laser etched line. That's 3 millimeters. So I know I want that line on the implant driver to be about 1 millimeter subcrestal from the freed interval margin. So the implant's driving in and the implant torques in well. I need the insertion torque for this implant to be 35 Newton centimeters or greater for the delivery of the provisional restoration. Double checking my measurements, showing you that I'm about 1 millimeter subcrestal. So now what we're going to do is I'm placing my sleeve guide for my bone mill. Because that implant is placed 1 millimeter subcrestal, if I try and put a healing abutment on or a tie base, it won't seat all the way. Remember, all of these components, when you're putting a healing abutment in, should passively tighten until you hear it stop. You shouldn't have to be slowly tightening it to effect. It should turn, 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 and then it should stop immediately. So here we are doing our bone mills. If you've never used these bone mills, I suggest getting a set. It will make your life so much easier, especially when you start placing your implants a little bit more subcrestal to allow for biologic width establishment. This is something I've learned over the last 3 or 4 years. So we use these drills every day when it comes to implant placement. Notice how I have a throw pack in. Really important to do for these cases. The next step is going to be to protect that implant interface, either with a healing abutment or with the scan body, whatever we want to use for this case. I always like to double check my implant positioning prior to moving forward with implant placement. So here's my 2 millimeter pin directly in the middle of the two adjacent teeth, exiting occlusally where I want it to be. With the surgical guides, it makes implant placement predictable, safe, and it really reduces my chair time. So here's our scan body in place. And the suture of my choice that I use as my daily workhorse is going to be a 5-0 glycolon on an 18 millimeter needle. So 2 interrupted sutures. And now we're going to scan for the provisional restoration. We have options when it comes to the tie base selection of choice. We have the option of an engaging tie base, as you can see right here, or the option of a non-engaging tie base, as you can see right here. Non-engaging meaning it will not engage into the internal hex. What do you notice differently about these two screws? Notice how this screw is longer as compared to this screw right here for the engaging tie base? Well, this is because this screw with the non-engaging tie base is the omni-grip driver or the angled screw channel driver. The driver of choice for the engaging tie base is the unigrip driver. So just things to consider that the engaging tie base has these wings, and you can see here that the restoration itself automatically comes indexed from Sprint Ray. It's incredible. And then I'm bonding this outside of the mouth. This is a different case. This was a day of training, so it's a molar on a model that we're just trying to learn how to do. So that just is for educational purposes, but just know we're bonding the tie base to the provisional outside of the mouth before insertion of that provisional restoration. Total working time for this, including design time. So design time from Sprint Ray Technologies is about 15 to 20 minutes, plus another 10 minutes to print, plus about another 10 minutes to polish and finish and bond. So about 40 minutes in total. So I just have the patient wait and relax, or we can send them to go get a cup of coffee and have them come back in the afternoon. You need to decide what workflow works better for you, but it's about 40 minutes of time, of assistant time. Just a closer view of that tie base. And really now, once Sprint Ray Technologies allowed us to print to the engaging tie base, this has been my workhorse. It works so well and so predictably. Very few remakes in our office when it comes to making these types of restorations. All right. So we're going to insert that restoration. So I'm going to irrigate out my implant body. I prefer to irrigate it with closest mouth rinse. Implant goes in. Contacts are nice and tight, right? So we won't get fluid impaction. I'm going to hand tighten first. I'm going to check those contacts. Then I'm going to torque this restoration to 35. With the engaging tie bases, the insertion torque recommended is 35 Newton centimeters. So you will see me checking everything out, and then we'll use our
Now it's
Teflon
touching.
tape.
It's a little bit shorter than the final crown here, but it looks almost completely like the tooth here. Okay. Hey.
Basically telling the patient it's out of occlusion. So here we are, snaps floss really well, and the rest is history. I prefer these contacts to be a little bit on the tighter side for my restorations, but out of occlusion. And the final step will be glazing of this restoration. But this is what our process looks like. A predictable, seamlessly integrated digital workflow at Arcadia Perio, giving us predictable results and shaping those tissue emergence profiles. And this works wonderfully in anterior cases. So in the upcoming cases, you're going to get to see two more immediate provisionals, one on an anterior immediate with a 3D printed restoration. But then too, I'm going to show you some different types of healing abutments in following cases and why I use different implants to allow for better emergence in the posterior area with different types of healing abutments. So I hope you enjoyed tonight's lecture in terms of planning these implants. Remember, if you want to see the step-by-step, jump over into my modern periodontal concepts. And in the upcoming lectures, you're going to get to see how I design these printed restorations within Sprint Ray. So just know today's lecture was that we can do it and that it works well. In the following lectures, you'll get to see how we do it step by step. I'll talk to you about the printer maintenance, how well it works, and really, will this type of printing technology benefit you in the office? And can it really reduce your lab costs? Really, with the printing technologies for me, I offset my lab costs, I invested in my practice, and I got my tax benefits as well when I bought the equipment. So we just have to understand, what are you doing in your office? What can we print that we're sending out to the lab? And is it economical to get an ROI on that printer? All of these things we'll talk about in other lectures. So that's one of the things that I really enjoy talking about, is a return on my investment in this technology and how it's really benefited myself and my patients. So I hope you enjoyed today's lecture in terms of implant placement with a 3D printed sprint rate guide using a 2 millimeter sleeve guide, printing to a engaging tie base with the Midas. That's kind of my digital workflow in a nutshell. So more on the step by step with how this works. But again, take that 3 question quiz, get that CE credit, and we will see you back at our next clinical lecture. Thanks so much and have a wonderful day.